What would the new model of delivery proposed in the white paper mean for the health workforce? Do you think that we're going to need more to deliver it?
What is proposed is earlier intervention, and what we know is that if you intervene earlier, that can reduce needs and an escalation of those needs over time. So I don't know whether it needs more. I mean, we certainly know that there is a workforce issue, so we have to address that. But whether kind of what's required to deliver experts at hand, plus specialist provision packages, is more than what we have now.
I think there is a case for repositioning some of the workforce that we have currently with the graduated model, that tiered response. But I think we also need to look at where that workforce should be, because it's going to be very different in different areas. If we've got a rural area, for instance, thinking about the experts at hand model, to make that work, it has to be about relationships, communication that the health specialist has with the school team. In a rural area, you've got more schools with smaller populations, so we're going to need more occupational therapists, speech and language therapists.
The white paper emphasises the need for earlier identification of needs. I'm just kind of wondering what kind of capacity and workforce change would be needed to make sure that we could deliver those earlier interventions and identify those needs earlier.
It's an interesting study which has just launched, the MOTIVE study, Modelling Therapies for Improved Futures, which is looking exactly at how many therapists will be needed to provide support into schools. That's due to conclude in February 2028. So I think that'll give us some really useful information about workforce modelling.
Speech and language therapy is something that's concerned me for a while. Partly because constituents get in touch about it a lot, and it feels like one of those areas that if this is working, it's regularly provided in school without the need for an EHCP, and now people with an EHCP that demands SALT aren't getting it. So in 2024, more than 66,000 children and young people were waiting for their first speech and language therapy appointment, with 20,000 waiting over 18 weeks. How are we going to be able to get these down, and in terms of changing the model so that we can get SALT just more available, but also, you know, kind of what do we need to build that capacity to make it possible?
So I think there's a number of things to answer that question. There is no doubt challenges with the current workforce and the need for an increased supply of speech and language therapists. I think also there's something around being able to jointly commission across a local area based on a local area need. We are seeing increasing challenges a lot with occupational therapists as well, of staff burnout from high caseloads. Everybody comes into the profession wanting to support children and families, and when you know children are waiting for a long time, we are seeing some therapists leaving the NHS and leaving the workforce entirely.
In my research, I found that 39% of speech and language therapists are considering leaving their roles, which strikes me as a crisis, given that this is a role we need more of. What do we need to put in place in terms of, if we're reforming the SEND system, if we're making it more reactive, what do we need to put in place to make sure that we're not losing those roles and that expertise that we need in the system?
I think it comes back to some of the things we've talked about that service models and commissioned models, and being able to have the capacity to support across universal, targeted and specialist levels. In that RCSLT survey in the autumn of 24, it was 40% of SALTs working in the NHS said they were considering leaving their current job. So it's a really worrying percentage.
So it's a specific NHS. Are the things that, from your perspective, the NHS needs to be doing better? You talked about workload. Is there something more is there kind of an esteem question? Is there a kind of people feeling that their job's delivering? What's the collection of factors that we need to make a new, just qualified from university SALT practitioner feel like they've got a future in the NHS and they can continue delivering, whether they're kind of working closer to the kids in schools?
I think some of it comes back to that significant variability about how services are delivered and commissioned. So in the service that I work for in Northumbria, we have a good retention rate of staff and we don't have long waiting times. There are many factors that contribute to how that works and that service model, but it's that variability across the country of what services are commissioned to provide and how they can utilise their workforce to do that. If you are going into a role that is almost assessment only, it's not as attractive as a role where you can actually deliver interventions and support children and families.
Thinking about the new model we're shifting to, how's that going to, do you think that's going to impact it? Now, obviously, one assumes if you're trying to get more early intervention, you are spending more time assessing, but I guess you're also able to make those interventions. Do you think that could work better?
I think there's some real positives in the information that's been outlined on the way forward, and I think the experts at hand model is welcomed in terms of being able to support that wider workforce, because everybody parenting, caring for and working with children and young people supports their communication. Yeah. So being able to work in that way to support the wider workforce to identify early and deliver evidence-based interventions would be really welcome. It's ensuring we have the capacity to be able to do that, and that expert at hand model is integrated into local services and not a standalone option.
You talked about different types of commissioning, and where you work seems to have a very good commissioning model, other areas have worse commissioning models. Could I quickly ask, one assumes you don't need the same commissioning in Hackney as you do in I don't know, rural West Yorkshire where I represent. So what are the elements of a successful commissioning strategy that means that people feel like their job is making a difference and they feel like it's worth continuing as a sole therapist?
I would say it's that joined up approach to looking at a local area need, and that we're not siloing off health professionals away from educational professionals, but actually that is that whole overview of how we support children's communication or children's health needs in partnership, and that there is a workforce plan and a strategy jointly that supports that.
And it feels like that would work across all of the elements, as if we can have that broader workforce, broader sense of meaning and mission. I'll hand back to the chair.